Let me tell you about the man who first opened my eyes. Just like many of you, thank you, Jeff Nelson, many of you, I had the opportunity to open your eyes so that you could see such an obvious thing that what you eat causes health or disease. Let me tell you how this happened to me. Mary and I met in, it was either August or September of 1971. We met in an operating room. She had a mask on. All I saw was her eyes. But I fell in love. It took me 3 weeks to get a date. Yeah. But once I took her out, she never left. Yeah. Well, anyway, we got together. It was about August or September of 1971. And towards the end of 1971, maybe December or so, I was a senior medical student. I was going to all these lectures at noon where the real doctors would talk about diseases, chronic diseases, and they talk about the signs and symptoms of diseases and how there's probably a gene related to them, and we can give this drug to help the signs or symptoms. But I felt helpless as a medical doctor because they never taught me about how to prevent chronic disease like arthritis or cancer or heart disease, and they certainly never taught me how to treat it. And then at this one noontime conference appeared a presenter. I had no idea who he was, but he changed my life. His name was Dr. Denis Burkitt. He was a surgeon. He was trained in Edinburgh, Scotland. And after his training as a surgeon, he left with Alex Walker and Clive and a few of his other buddies, and they went to Uganda, Africa, to help people in Uganda, Africa. And he stayed there for 17 years and became the head of ministries of health of Uganda. Dr. Burkitt oversaw 1,000 hospitals and took care of indirectly and directly 10 million people over 17 years. And Dr. Burkitt came to that noontime conference and he stood up there in front of the audience, and I was sitting there and he was only talking to me. He stood up there and he said, in my 17 years in Uganda, as the head of ministries of health, 1,000 hospitals, 10 million people, he said, I never saw a case of hemorrhoids. I never saw diverticulitis. I never saw obesity. I saw one case of gallstones. I never saw colon cancer, rheumatoid arthritis, lupus, multiple sclerosis. I saw one heart attack, and that was in a judge who trained in London and came back to Uganda and had a heart attack. He told me that. I was so excited. And he told me it was because of fiber. It was because of the fiber they ate. That was who he's focused on, but you all know that fiber only occurs in plants. So what he was talking about is the diet of the people of Uganda, which was a starch-based diet with fruits and vegetables, no dairy, and extremely little meat. That was back in the 50s and 60s. And I came home after that lecture, and I'm sure Mary remembers it. And I said, Mary, I heard this man talk about fiber, and I just want you to know, we're no longer eating white bread. We're going to have brown bread with our bacon and eggs. Yeah. But it opened my eyes. My eyes were opened. I could see finally that there was a cause of disease. Took my plantation years and then my going back to become an internal medicine specialist before I really got it. And studying after that, after I discovered the importance of diet and diseases, I told you a couple of minutes ago, I wanted to know everything. But let me just give you a minute. The only interview ever done of Dr. Denis Burkitt I did. It's in my January 2013 newsletter. It's an hour-long interview. He has a Scottish brogue. He's a little hard to understand. But if we can get the chance to hear him, let's try.
If you look at the diet of disease of the countries throughout the world who don't get the common diseases of Western culture, and when I say the common diseases, I mean diseases like atherosclerosis, diabetes, gallstones, bowel cancer, breast cancer, hemorrhoids, varicose veins, diverticular disease, huge pile of stuff. The countries who don't get these diseases have a diet with far more starch, far more fiber, far less fat, far less sugar, far less salt. And the two major things we need is to eat more fiber and less fat.
Okay, did you hear him use the word starch? Yeah. We used to call the food that I recommend starch. Potatoes, rice, corn. For those of you who don't know, I believe 70 to 90% of your diet should be starch. You heard Andrew Taylor, the potato guy. Hopefully you've gotten that theme, is what most of your food needs to be is starch. And Dr. Denis Burkitt told you about the common diseases. He didn't see colon cancer, heart disease. He told you. I remember his presentation, and the only slide I could really remember, and I tried to reproduce it, was this one. During that noontime conference in 1971. That's a slide where he showed in 2 frames. In one frame, he showed tiny rock-hard bowel movements and big hospitals. In contrast to countries and populations that have little hospitals, they have big bowel movements. Do you understand the connection? Well, let's try and listen to Dr. Denis Burkitt again.
Well, you see, I spent years recognizing that fiber related to bowel behavior, recognizing that in people who had adequate bowel behavior, they virtually never had a lot of our Western diseases. And I really copied the example of my friend Alec Walker in South Africa, who has looked at thousands of stools. But you see, now we know from the evidence available that the average American who isn't a vegetarian only passes about 80 to 130 grams of stool a day. In people and elderly people under 50. Whereas in countries that don't get bowel cancer, breast cancer, gallstones, coronary heart disease, so on, they pass 3 to 500 grams of stool a day. And I think we are genetically, as it were, coded up or made to get on with far more fiber than we take. And I think our relationship to, well, there was always causative relationship, but our relationship to a lot of our Western diseases is related to what I might call our national constipation.
Okay. All right, so far, based on what I learned from Dr. Winder and what I learned from Dr. Burkitt, Dr. Denis Burkitt, it's obvious that colon cancer and colon diseases are caused by what we eat. I mean, that's enough. Don't you think that this experience, which occurred in the 1970s, should have transformed medical care over the last 40 years? But it hasn't. You will hear nothing about what you put in your colon in terms of your health. Just the way it is. Let's see, colon cancer. Let me tell you a little bit about how colon cancer works, and I'll tell you how cancer works and why what we do fails so much. When you put bad food, and bad food is a good enough description. When you put bad food into your intestines, it eventually ends up in your large intestine, the remnants after digestion. And these remnants of food that end up in the large intestine, they have carcinogenic properties. For a whole bunch of things that you can learn about that I've written about and other people have written about, changing bowel flora, direct chemicals, etc. And these carcinogens, these substances, they irritate the colon wall. And the consequence of irritation of a mucosal surface, which is found like in the nose and the mouth and in the bowel and on the cervix, the consequence of chronic irritation on these mucosal surfaces is proliferation. If you irritate, say, the skin, which is a different kind of tissue, you get keratin production, calluses. Okay, that's the way the skin reacts. But the mucous membranes, they react by the cells proliferating. So we start out with these cells proliferating as a consequence of injury. And as you see the progression, they proliferate into small lumps, which we call small polyps. We call them polyps. And then they get into bigger polyps. It takes about 15 years of irritation for the colon to turn into a polyp big enough to be a colon cancer. It takes about 15 years. And then after it becomes a colon cancer, it goes into the bloodstream, the venous blood, the cancer cells. You don't even know you're sick. You've got a little thing inside your colon, a little polyp that may be half an inch in size. And it becomes cancerous, and then the cancer cells go into your veins, and then they spread throughout the rest of your body. And it takes about another 15 years to kill you. So once you get that timeline, is on average it takes 15 years to turn into a cancer and another 15 to kill you. All right, you have to keep that in perspective as we do carry on our conversation. So let's take a look at cancer in general: prostate cancer, colon cancer, breast cancer. Cells get irritated, like breast cells and prostate cells and colon cells. And when they get irritated really bad, most of them die. But sometimes one doesn't die. It just gets irritated bad enough to stop obeying a basic rule of cells, which is you can't go divide at any time you want. See, cells are programmed so they divide when you grow from a little child into an adult. And cells are programmed to divide, say, if you get an injury, cut your hand, they can divide. But otherwise, they can't divide at their own free will. Otherwise, you'd be a misshapen lump in a matter of hours. Let's look at just for this demonstration, let's consider this a cell in the prostate or breast. So one cell stops obeying the rules. It becomes cancerous. A breast contains 100 billion cells. One breast. Two breasts. Okay. A prostate contains 100 billion cells. So you have one cell that becomes cancerous, and it starts dividing at its own free will. And the average dividing time is every 100 days. We know that. You can look at all this science if you're interested. We've known this since the 1950s. So after 3.5 months, you've got two cells in a breast containing 100 billion cells. Another 100 days later, you've got 4 cells in a breast that contains 100 billion cells. At a year, you've got 12 cells lurking in a breast that contains 100 billion cells. Now, at 2 years, you've got maybe 100 cells that are cancerous. And by that time, if it's really cancer, it's already leaked into the venous blood and it's spread to other parts of the body where it seeds in the brain, liver, lungs, etc. And it starts growing at a similar rate. Okay, let's go back to the breast or prostate. So you've got 100 cells in an organ that contains 100 billion cells. These divisions continue, and finally at 6 years of having cancer, at 6 years, you've got a tumor mass that's the size of a period on a paper. It's the size of a lead tip of a pencil. It contains 1 million cells. It's a millimeter in size. You've had cancer for 6 years. If it's truly cancer, it's already spread. But you can't find this. There's no way to find this anyway. So let's go back to the organ. The cancer continues to divide in the prostate or breast, and finally it gets to be a centimeter in size. That's the size of an eraser on a pencil. And now it becomes detectable. Now you can feel it in your breast, or your doctor can feel it on a rectal exam. Or if you get a PSA test, now it's big enough to elevate the PSA. It's after 10 years of development and 1 centimeter in size. That's what early detection is. It's late detection. 2/3 of the disease goes unnoticed by the patient or physician. And yet we're being sold techniques to find these little cancers, which really aren't little. They're big, and they're already destined, if they're destined to do bad things to people. However, you can change the course. Let me add this to it. It's very important. It's in my February 2015 newsletter. Is now the American Cancer Society recognizes and tells doctors that if a patient has breast, colon, or prostate cancer, or melanoma, or other kinds of cancer, if they change their diet, they will live longer. That's the official recommendation of the American Cancer Society. So I gave you this time lapse here of dividing every 100 days. Well, what if you can have the tumor divide every 800 days? What if you eat good and you slow it down, you perk up the immune system, you stop encouraging the cancer to grow, and you can change that doubling time? Then you die of breast cancer when you're 176. And by the way, I know this happens. I know you can change these doubling times by changing what you eat. You don't want your tumor dividing every 34 days. You want it dividing every 800 days. You follow this? Okay, now that I brought you up to what cancer is and how it grows, I want to get back to early detection. Let's just talk about colon cancer for a minute. We already talked about mammography at the introduction of H. Gilbert Welch. Let's just talk about colon cancer. There are various ways to screen. Remember, it's doctors going out to healthy people and looking at healthy people for disease and turning them into patients. There are various ways that you can do that. You can do it by checking the blood, checking the stool for blood in a couple of different ways. You can also check the stool for DNA. It's called a Cologuard test, and that checks for cancers type DNA that's found in polyps or colon cancer. You can also do various scope procedures. You can do a sigmoid procedure, which is like a 2-foot tube that's put up your bottom, or you can do it with a 6-foot tube, which is called a colonoscopy, which can be put up your bottom. And you can do X-ray tests. We call them virtual colonoscopies. We used to do barium enema. So there are various ways that you can detect whether or not you have colon cancer. All right. I have recommended against colonoscopy, that 6-foot test, for a long time. Actually, August of 2010, I sent you all a newsletter. Well, interestingly, this year, the Canadian Task Force on Preventative Medicine told the Canadian citizens to stop getting colonoscopies. Yeah. You see what they say? They say, we recommend not using colonoscopy as a primary screening test for colorectal cancer. That's what the Canadian Preventative Task Force recommends. Why? Because it does more harm than good. I wrote you a big newsletter about this called Colonoscopy, a gold standard to refuse. I sent it to you in 2010. But when I told people that, they do think about me a lot. They think, you're just being radical or crazy. And, why would somebody not want to find out if they have cancer in the breast or prostate or colon? This is just stupid thinking, McDougall. Well, except for the fact that looking for all this disease does a tremendous amount of harm. Especially when we don't have effective ways to treat it. And how in the world could we possibly treat it when early detection is finding something that's 10 years old and already spread? So here's the kind of test you can have. Here's your colon. You see the large intestine there in the darker red color. You can go to your doctor and you can have a 2-foot tube. We use flexible ones now. When I was doing them as a general practitioner, we used this silver sword. It was some of you may have had this done. I used to do it almost daily in my office 40 years ago. But now they do a flexible exam, which requires no anesthesia, real simple office procedure. And it checks the first 2 feet or the last 2 feet of the colon. Or you do a colonoscopy where they stick this tube. You see all the bends and turns they have to take? 6 foot long, they can study the whole intestinal tract, and you'd think that made a lot of sense to study the whole intestinal tract, but it's not what we find. What we find is just looking at the first 2 feet of the colon with a sigmoid exam is the only test or the only examination that will save patients' lives. Colonoscopy doesn't do any better. In fact, we'll get to that in a few minutes. So why, when you go to a doctor, are you always told to get a colonoscopy? When the Canadian Task Force says don't, when the scientific research says it doesn't work, why do all your doctors recommend this extensive test? Cash is king. We can screen you with checking your stool for blood, say do it every couple of years, for a test that costs $30 to $40. I can do a sigmoid exam on you as a doctor in my office without anesthesia for $200. Or I can take you to your local hospital or medical center, as the gastroenterologists do, and they can stick a 6-foot tube up your butt, give you a sedation or anesthesia, and then charge you $3,000. Okay, here if you want to look at the absolute survival, let me take a look at what I said here. If you see now what we're talking about is reducing the risk of dying of colon and rectal cancer. There's no reduction in overall mortality. It just changes how you die. So you can reduce the risk of dying of colon and rectal cancer. If you check the stool, you can decrease 2.7 per 1,000 deaths by doing colonoscopy. If you screen 1,000 people, you can save people from dying of colorectal cancer, 2.7 people, or in other words, you have to screen 377 people to prevent one death from colorectal cancer. I hope you're hearing me. I'm saying colorectal cancer. Or you do a sigmoid and you have to screen 850 people. Now, read that sentence there. These numbers reflect a decreased risk of dying from colon cancer, but not from overall death. Nor does mammography, nor does PSA testing. They just change your method of dying a little bit, tiny bit, not much. And the reason is, let's just get back to colon cancer, is because colonoscopy kills. Yeah, people die from perforation. I've known people, I bet you do. I bet if I sit and mention this to you for just a minute, you'll say, well, I had a friend, perfectly healthy 40-year-old woman who was doing what was recommended to, prevent dying of colorectal cancer, and went into the medical center, had an anesthesia, perforation, which happens in 1 in 2,000 examinations, and about 40% of these people die. Yeah. Well, let me just say it another way. Screening, what screening is, when you ask to get screened, what the doctor, what the medical profession is asking you to do is to risk your life today for the theoretic possibility that you have less chance of dying of colorectal cancer 10, 20, or 30 years from now. Think about it. And I can make the same argument for mammography, similar argument, that it does a lot of harm. All right. So here's an article that came out in JAMA Internal Medicine, and it's a good one to read. You can read it for free. JAMA Internal Medicine is an open access journal. And they say fecal blood testing or colonoscopy, what is the best method for colorectal cancer screening? And in that article they say, however, there is no randomized clinical trial or other high-quality evidence showing that colonoscopy reduces colorectal cancer mortality, not just overall mortality. Colonoscopy has not been shown to reduce even dying from colorectal cancer. And that, the only thing that's reduced the risk of dying of colorectal cancer is checking the blood or having one sigmoid done at age 60. Why do you start checking at age 60? Well, if you check earlier, you're screening a lot of people who are not going to have colon cancer. You may be saving a life, but look how much risk you're putting at people at. If you screen at age 60, if I check your colon, say by blood or a sigmoid exam, and I conclude that there's nothing wrong, say the next day, you're 60 years old, say the next day you start that cell proliferation. Then the cells proliferated into a polyp, which turns into cancer 15 years later. So now you're 75. And it takes another 15 years to kill you, and now you're 90. So at the most I can recommend, and I do recommend it, is for people to check their stool for blood every other year, say when they get to be about 60. After 75, don't. And have one sigmoid exam done at around age 60. But I had to tell you the general history of cancer so that you can understand why early detection is a misnomer. Why, because you say to me, I know some of you are thinking, even though most of you are my friends, you're thinking, McDougall must be crazy to tell people not to get mammograms or PSA tests or to do dangerous examinations like colonoscopy. I mean, what is this man thinking? Well, if you understand the natural history of the disease, then you understand, every doctor should know this. Every doctor, this is common knowledge. There's nothing questionable what I told you. But if you understand it, if you understand how this disease grows and progresses and so on, you understand that you must prevent cancer. You can't early detect it. You must not smoke. You must put good things in your colon. Because catching it early, which everybody'd like to have the easy way out. I don't want to change my diet. I don't want to quit smoking. I want you to catch it and treat it for me. Well, that would be great if it worked, but it doesn't. And if you don't know that, then you won't put the energy where you should put it. That's why I told you this. Yeah.